Hi there, I'm Dr. Meaghan Nelsen, and this is the hands-on portion for an osteopathic approach to the 4th trimester. So starting with the maternal half of the mother-infant dyad, for her initial postpartum assessment, you can perform this in a seated environment if that's what is best for you, your office arrangement, or for mom's comfort. But also at this point in time, now that they are no longer carrying around that 9-10 month fundus, I invite moms, if they're more comfortable, to go ahead and lie supine on my table. So lay flat on your back with your mouth up towards the ceiling for me. Thank you. I begin my approach with my screening exam. My preference is for a supine postural examination. So with mom comfortable supine, and this is also advantageous if baby gets fussy and is able to latch to mommy in a reclined position, baby can join us for the remainder of the encounter. But starting with gentle translation, this is how I do my broad screening, but then proceeding from inferior to superior, the same way that you'll see that we'll screen the infant, I'll examine for tib-fib restrictions. Okay, if you feel the heels of my hand along your pelvic bones, your hip bones, and start examining that pelvis using a gentle ASIS compression test, as well as placing my thumbs underneath the ASIS and start evaluating for symmetry or lack thereof. With your permission, I'd like to examine the pubic bone, which lies just in front of your bladder. I'll use the heel of my hand from about the waist of your pants and walk down until I find that bony landmark. Is that acceptable to you? If at any point you're uncomfortable, please let me know. And then I replace the heel of my hand with my thumbs and examine for pubic dysfunction, which she does not have. Now, alternatively, if it is more comfortable for you or you feel better about identifying landmarks, you can invite your patient. There is a pubic bone. It's the bone right here in front of your bladder. Would you try to localize that for me, please, with your fingertips? And once mom locates, you can say, okay, my thumbs are going to replace your fingertips, and find that way just as easily if you're less comfortable with the inferior approach. So from there, I will continue my screening across her costal cage using translation, and this is a chance for me to examine for myofascial restrictions of the thoraco-abdominal diaphragm. While I'm here, I can feel free to treat with myofascial release. Continue up that costal cage, and as I find these restrictions, I tend to use BLT for the ribs, but if you're more comfortable using muscle energy for inhalation exhalation dysfunctions, anterior and posterior dysfunctions, you absolutely may do so. I tend to slide my hands underneath, and you're going to feel the fingertips on the ribs along your breastbone. Is that okay? So I first find the sternum and then move to that costosternal junction and find that I'm on the same rib, and apply my balanced ligamentous tension. And it's not that you need to treat every rib, just those ones that you find dysfunctional. Now, in a postpartum mom, regardless of her route of feeding, she is very likely to have a majority of her restrictions from the diaphragm moving cephalad. If she's been treated once postpartum, a lot of times we eradicate the pelvis and sacral dysfunctions, though I will show you some approaches to the sacrum. But in subsequent visits, especially in those moms who are coming to see me who are struggling with breastfeeding, they spend so much of their day in this heavily flexed position with their arms abducted to the side. They get elevated first ribs and things like that from coddling the baby, bouncing the baby, burping the baby, establishing that latch, bottle feeding, whatever the case may be. They live like this. So once you've done your initial treatment of that pelvis and sacrum postpartum, for those successive visits, it's a lot of things from the diaphragm moving up towards the head. So once I've treated those ribs with BLT, then I come to the head of the table, because as I just explained, once you've released those ribs, there's still going to be myofascial restrictions or spasms in her pec muscles. So I like to scoop into the armpit, clear my fingers around that pec muscle, and you can apply traction in either direction. So her left pec is more restricted than her right. So I'm matching that tissue tension, doing a myofascial release. Also somewhat of a direct inhibition technique, but that's just nomenclature semantics. And once her pec muscles are released, I then will come to her thoracic inlet or outlet, because remember, as we talked about during the slide deck, there is no inherent lymphatic drainage of the lactating breast. It requires the movement of the costal cage that accompanies respiration. So I want to be certain that I'm removing all of the restrictions and the anatomical attachments to that lactating breast, but then also opening up her thoracic inlet or outlet so that drainage can occur and she doesn't suffer recurrent clogged ducts, mastitis, things like that. So coming to her thoracic and lower outlet, she is currently flexed, side bent to the right and rotated to the left. I can choose to take her there and exaggerate those freedoms with an indirect technique. If you were more comfortable doing the inverse, you can extend her, side bend her to the right and rotate her to the right, applying a direct myofascial release, taking her towards her barriers. And once those myofascial restrictions are released, I'll almost repeat my translation the same way I started at the bottom. I'll rescreen as I'm here at the top to make certain that I've freed up everything I wanted to, coming up to the cervical spine. If you are more comfortable doing FPR, BLT, muscle energy, thank you so much, Mom. You can screen this cervical spine, apply HVLA, whatever techniques you feel comfortable with, but most moms will have a restriction in multiple segments of their cervical spine, but I would venture to say that this mom might enjoy gazing down at her baby more towards the right, or lives more this way because she has some significant paravertebral muscle restrictions all along her right cervical spine. So you can do soft tissue, you can do myofascial release, you can do localized segmental muscle energy, but also you can do, again, more of a broad spectrum technique where you bring her up into flexion and have her push her head back against you. Go ahead. Good, and relax and bring her further into flexion, but then also you can get a little bit of side bending and rotation by bringing her towards the right. Go ahead and push back into me again, Mom. Thank you, and relax. And then I can take her in the opposite direction again. Go ahead and push against me. Great, and relax. I love this as, as I call it, a broad spectrum, but it's a wonderful warm up for that cervical musculature, even down into the traps. And moms who have been spending so much time in this hyperflexed, thoracic kyphosis position, they'll feel that stretch all the way down to T12, to that distal attachment of the trapezius. And then finally coming up to her head. Most moms, again, contributing or attributed to the positioning that they spend most of their days in, their OAs will be flexed. So her OA is flexed, side bent to the left and rotated to the right. You can apply BLT, you could apply muscle energy, whatever technique you feel best with, but apply that OA decompression technique or even suboccipital inhibition if you don't feel comfortable with an OA diagnosis, but you do feel comfortable with the application of suboccipital inhibition. You can just assume this posture and at least apply, match your tissue tension, your finger application, your pressure to that tissue tension, and release all of the muscles that insert there at her nuchal ridge. You can at least release those if not directly treating her OA. Lastly, this is where I would start my cranial, but that's outside of the scope of today's lesson. Going back to her pelvis and sacrum, if you are comfortable with seated techniques, supine techniques, prone techniques, you do whatever works best for you and your patient. But in this supine position that I'm showing you, I'm just going to ask you to take your glasses and put them back on. You're in the proper setup where if she has a posteriorly rotated innominate, for example, very easy to guide her leg off of the table and stabilize the contralateral pelvis to do muscle energy. This also works if she has a pubic dysfunction. If she had the opposite, you're in a great position to again apply muscle energy for an anterior innominate by bringing her posteriorly and she pushes into her shoulder. And lastly, when you're in this position, I'm going to bend this knee for you. If you located some sort of pubic compression or pubic gapping, you can apply shotgun muscle energy from here. And that's where I alternate compressing the knees together and asking Mom, separate your knees for me for 5 seconds. Good, and relax. And then I'm going to put a fist between your knees. Go ahead and break my fist. Crush it, crush it, crush it. Good, and relax. And then we go back to the compression. Separate your knees for me one more time. Good, and relax. This time I'm going to put 2 fists. Go ahead and break both hands. Crush them, crush them, crush them. Good, and relax. Third and final round. Go ahead and separate those knees for me. Good, relax. And lastly, I'm going to use my whole forearm. This one's going to be tough. Go ahead and squeeze together, squeeze together, squeeze together. Good, and relax. And that's, again, a ubiquitous or shotgun, broad spectrum approach for pubic dysfunction. So all just in this one position. Majority of these techniques can be done with baby on chest, as I said, but I'm gonna have you go ahead and sit up and face the camera one more time for me. If for whatever reason mom is more comfortable in a seated position, you can do everything from cervical soft tissue, thoracic inlet outlet, taking care of thoracic and lumbar muscle energy, ribs with BLT or muscle energy, and even some posterior sacrum, SI joint BLT in the seated position, and then choose only to lie mom down to get to those innominate rotations if necessary. But as previously stated, if this is a postpartum mom whose pelvis and sacrum have been realigned and they're balanced and free of restrictions, and she's here and you're working on her lactation journey, applying treatment in this seated position with or without baby on board is perfectly lovely and will allow you to access a majority of those restrictions that she will have.